Hi friends, welcome to my YouTube channel Future Midwife. For the past few classes, we were discussing about the antenatal conditions such as diagnosis of pregnancy, antenatal care, physiological changes during pregnancy, antenatal exercises, so on. All those conditions gives a pleasurable moment to the woman. So, once the woman recognizes she is pregnant, that will be a most pleasurable moment in her life. Once she recognizes she is pregnant, both physically and mentally she is ready for the motherhood. If the conditions are going in such a way, so once in a while, if she hear the word abortion or miscarriage, that will be the bad situation for her life. Being a woman, I have experienced such kind of situation in my life also, as I had a 5 miscarriage in my life. So hopefully at the end, God has given me a child. Okay, so without wasting time to discuss about my personal experience, let's we start today's topic, abortion. Even though abortion is a bad situation to women, but we need to learn about abortion because it has to be included in our nursing syllabus. So in the examination, most of the time abortion will be asking as a short essay, or sometime it may come as an essay question. So definitely nursing student should learn about abortion. Okay, well, we'll start with today's topic with a definition. Abortion is otherwise called miscarriage. It is a condition where the ending of pregnancy by removing fetus or embryo before reaching the viability. Abortion, it can be induced or spontaneous. According to WHO, abortion is a condition where the expulsion and extraction of fetus or embryo weighing 500 gram or less when it is not able to survive independently. Next, we'll see the incidence. The incidence of abortion is difficult to work out, but probably 10 to 20% of all clinical pregnancies ends in miscarriage, and another optimistic figures of 10% are induced or deliberate. About 75% miscarriage occurs before the 16th week of pregnancy. Next, we'll move on to the classifications of abortion. The abortion can be classified mainly into two, spontaneous and induced. The spontaneous abortion can be classified again into two, that is recurrent and isolated. Both the classification again divided into inevitable abortion, threatened abortion, complete abortion, incomplete abortion, missed abortion, and septic abortion. So we'll see one by one. The etiology of abortion are always complex and obscure. Some of the etiology are anatomical reason, genetic reason, immunological factors, infections, and endocrinal issues. So next, how we can diagnose there is abortion or miscarriage. Each type of miscarriage, the clinical features are different. Commonly, we can identify the miscarriage by means of quantitative HCG blood test, pelvic examination, ultrasound scanning, and fetal heart rate monitoring. The first we'll see about threatened abortion. Threatened abortion is a clinical entity where the process of miscarriage has started but has not progressed to a state from which the recovery will be possible. The main clinical features are fresh vaginal bleeding without any abdominal pain or uterine contraction. Most of the time, the fetal heart rate will be positive, and with the help of a proper rest and hormonal support, she can continue the pregnancy. When we discuss about inevitable abortion, it is a clinical type where the changes has progressed and which reach to a stage the continuation of pregnancy cannot be possible. The main clinical features include there is a severe vaginal bleeding along with the uterine contraction. So the mother experiences severe vaginal bleeding and the severe abdominal pain. most of the time there will be a dilatation of the internal os also. When we discuss about the treatment, it can be depending upon the gestational weeks. So mainly it can be divided into two ways, before 12 weeks and after 12 weeks. Once it comes to the condition before 12 weeks, we can do the treatment by means of dilatation and evacuation followed by curettage of uterine cavity. So if it is after 12 weeks, the uterine contraction is accelerated by oxytocin drip. That means 40 to 60 drops per minute. If the fetus is expelled and placenta is retained, then D&E is done under general anesthesia. Next type of miscarriage is complete miscarriage. A complete miscarriage is defined as a cessation of vaginal bleeding with no evidence of retained product of conception or a gestational sac in a woman who previously had an ultrasound confirmed intrauterine pregnancy. The main clinical features include abdominal pain, vaginal bleeding, uterus is smaller than the period of amenorrhea, USG shows that uterine cavity is empty. When we discuss about the incomplete abortion, there is a cervical dilatation along with a severe vaginal bleeding, but at the same time the uterine product will be remain inside the uterus. The clinical features include there is severe vaginal bleeding along with the uterine contraction. So once we do the PV, the dilatation will be the tip of the fingers. Then when it comes to the USG, there will be echogenic material activity inside the uterus. The main management include dilatation of the cervix with the misoprostol if it is not dilated. If it's already dilated, no need to keep the misoprostol. Then D&C or D&E can be done. Next type of miscarriage is missed miscarriage. When the fetus is dead and retained inside the uterus for a variable period, it is called missed miscarriage or early fetal demise. The main clinical features include persistence of vaginal brownish discharge, subsidence of pregnancy symptoms, non-audibility of fetal heart rate even with a Doppler or ultrasound. USG shows and sac with the absence of any fetal movements or cardiac motions. In case of missed miscarriage, the obstetrical management will be depending on the gestational age. Usually, if it is before 12 weeks, spontaneous abortion will be takes place. That means no need to go for any curettage. So if it is not dilated, that means the cervix is not dilated, we can use prostaglandin E1, that means 800 mg vaginally. So once it is dilated, we can do D&C or D&E. If the gestational age is more than 12 weeks, for the dilatation we can use oxytocin. If it is more than 12 weeks, we can use oxytocin for the dilatation of the cervix and initiation of uterine contraction. So we can use 10 to 20 units of oxytocin which can be diluted in 500 ml of NS. The drop rate will be 30 drops per minutes. So once it initiates the uterine contraction, automatically the uterine product will be expelled from the uterus. Here we reach the last type of our abortion, that is septic abortion. Any abortion associated with the clinical evidence of infection of the uterus and its content is called septic abortion. Mode of infections are through microorganisms which are anaerobic bacteroids, streptococci, Clostridium welchii, Pseudomonas Escherichia coli, methicillin-resistant Staphylococcus aureus. These all are the mode of infections. In case of pathology, in the majority the organisms are endogenous origin and the infection is localized to the conceptual without any myometry involvement. In about 50% of infection either produces localized endometritis surrounded by a protective leukocytic barrier or spread to the parametrium tube ovaries. In about 5% there is generalized peritonitis or endotoxic. The clinical features of septic abortion include the mother looks sick and anxious. The most of the time there will be chills and rigors. Sometimes there is hypothermia. The renal angle tenderness will be possible. And there will be a vaginal discharge. The nature of vaginal discharge is offensive purulent vaginal discharge. Along with that, there will be severe abdominal pain. There are many investigations to identify the septic abortion, which include swab culture to find out the dominant microorganism, sensitivity of microorganism to antibiotic and smear for gram stain, urine analysis including culture, blood for hemoglobin and count of WBC, plain X-ray to suspect bowel injury. USG can be done to detect any product inside the cavity, fluid accumulation in pouch of ductless. In case of management, hospitalization is essential for cases of septic abortion. To take high vaginal or cervical swab for culture. Vaginal examination is done to note the state of abortion process and extension of infection. Antibiotic and analgesic is very important. Evacuation of the uterus, and the last one is posterior colpotomy is done in some cases. In case of recurrent miscarriage, there will be more than 2 or 3 spontaneous abortion. It should be happen before 20th weeks of gestation. The main causes of recurrent miscarriage include genetic, metabolic, endocrine, immunological factors and so on. Here we reach the nursing management. The presenting symptoms of the abortion is always vaginal spotting, and once this is noticed by pregnant woman, she should immediately notify her healthcare provider. Ask of the pregnant woman's action before the spotting or bleeding occur and identify the measures she did when she first notified the bleeding. Inquire of the duration and intensity of the bleeding or pain felt. Lastly, identify the client's blood type for cases of RH incompatibility. Here we can wind up our today's section. So this is a brief description about abortion types and its management. So next class we will meet with another episode of midwifery topic. Till that, take care. Bye bye.